Oh, good evening. Today we are having an online CME on bile duct injury and the surgeon. And the speaker is Dr. Adarsh Chaudhary. And the moderator shall be Dr. Abhimanyu Vasu. And being the convener, I request the president of Amasi, Dr. Varghese, to say a few words before we start. Please.
Yeah, thank you, Dr. Vishrub, and welcome to once again to the online CME program of Amasi that is being done on the every first Thursday of every month at 8 p.m. Indian time. And today's topic is going to be on the bile duct injuries. And we all know that the laparoscopic cholecystectomy has become so popular, but the incidence of the bile duct injuries that happening during the laparoscopic cholecystectomy is more compared to that of open cholecystectomy. So we have to do all the measures to bring down this incidence. As a part of that, Amasi is committed to the Safe Lab Chole programs like Safe Lab Chole, which is being done all over the country. In fact, we had one such program recently in the Maulana Azad Medical College in Delhi, and it was well attended and appreciated. So I think that more programs like this is definitely required. But to speak, we also should know how to manage these direct complications. And to speak on this subject, we have Professor Adarsh Chaudhary, an authority on this subject. And we all know that, Sir is, with the experience in this area as an HPP surgeon. And we all are looking forward to this today's talk from Professor Adarsh Chaudhary, sir. And welcome you, sir, for today's program. And today's the CME program is going to be moderated by Dr. Abhimanyu Vasu. He is the Vice President of Amasi. And each CME program is conducted by the zones of the Amasi. There are 5 zones and on a rotation basis. So this time it is going to be by the East Zone. And the Vice President of the East Zone is Dr. Vishrub Bose, and Dr. Vishrub will be coordinating the events today. And at this time, we are introducing a quiz program for the postgraduates. And there will be 2 questions asked, and one in the beginning and one toward the end of the CME program. And the winners will be, getting attractive prizes. And the quiz program will be conducted by our secretary, Dr. Deboshi Sharma. And once again, I welcome all of you, our friends from the neighboring countries and the postgraduates, surgeons, all from all places from India and abroad for a program. And I request all of you to be a part of all the educational activities of Amasi and also a part of Amasi also. Thank you very much. You are muted, Vishrub. Hello,
Vishrub. Thank you, President, sir. May I now request our Secretary, Dr. Deboshi Sharma, to put forward the first question, please, before we hand over the event to our moderator to conduct.
Thank you, Varghese, sir, and Dr. Vishrub. We are, as said, we are coming up with the quiz, which you just need to click the question, and there will be a pop-up where you can put in your answer, and it has to be within 2 minutes. The question, as pertaining to the topic that we have, is that which is the most common type of bile duct injury that we see? Which is the most common type of bile duct injury? You have to write which class of injury we get most commonly, and within 2 minutes it has to be passed on. And after this question, we'll have another question after the end of the lecture, before the discussion starts. So I wish all the postgraduates who are listening to this quiz or to this lecture all the best. I request them to give the answer to which is the most common type of bile duct injury that you see in today's era. I think we can go ahead with the lecture, and
yes.
In the
Thank
meantime,
you, Dr.
They will be able to answer.
Yes. Thank you, Dr. Deboshi. So now I request our moderator, Dr. Abhimanyu Vasu, the HOD of the Surgery Department of IPGMR, to moderate the session and invite Dr. Adarsh Chaudhary to speak on this topic.
Hello. Hello.
Yes.
So, sir, Adarsh Chaudhary, sir, please start your talk without
Okay.
delay.
Okay. So I want to share the screen. Somebody else is sharing the screen.
Take people, please. Sir, we can see you.
Okay. Right. So can you see my
Yes, sir.
slides?
Yes, sir. Yes, sir.
Okay.
Please carry
Thank
on.
you so much for inviting me today. The topic is very relevant since ages. My talk about post-cholecystectomy bile duct injury essentially will be talking only on assessment and management of these injuries. Prevention is a separate talk. It's a long topic. So I'm going to talk about how do we assess a patient who's got a bile duct injury and how do we manage these patients. A patient who suffers a bile duct injury following laparoscopic cholecystectomy can classically present in 4 ways. Patients may present with bile peritonitis when there is leakage of bile into the peritoneal cavity, or they can present with biliary drainage from a drain which is placed, or a patient might present few days after laparoscopic cholecystectomy to the surgeon's dismay with obstructive jaundice. And a subgroup of patients have none of these symptoms but keep presenting with recurrent attacks of cholangitis. If you take these presentations and their implications, if you see a patient who's got bile peritonitis, is the most dangerous patient, but also it's the easiest to manage. You drain the biliary collection, you do it laparoscopically, you do it radiologically, you do it by laparotomy, it doesn't make a difference. The main thing is to get the intra-abdominal bile out. Patients who have bile leak are the most improperly investigated. They undergo various investigations, and the most confusing part of managing is these patients. Patients who present with jaundice are usually managed well because it's understood, and patients who have cholangitis are most often missed because a surgeon does not realize that the cholangitis is occurring because a segment part of the liver is not being drained. So these patients, the bile duct injury is mostly missed. When a patient gets a bile duct injury, what is it that a surgeon needs to know? First and foremost, a surgeon needs to know, is there an intra-abdominal collection of bile or not? The leading cause of death in patients who have a bile duct injury following cholecystectomy is intra-abdominal sepsis, and that occurs because the intra-abdominal collections are undrained. So my first priority is to rule out an intra-abdominal collection, and my strong bias is that these patients should undergo a CT scan instead of an ultrasound, because ultrasound is a very subjective investigation. Of course, if you have a radiologist whom you can trust, who's good at ultrasound, you can trust that. But most important thing is to rule out an intra-abdominal collection of bile. Second is I want to know what's the level and grade of injury. My second priority is to know, is there an associated injury to the right hepatic artery, main hepatic artery, or portal vein? Because that determines the outcome and the implications of these injuries. And also patients who present later, it's important to understand, has there been an associated sequelae of this bile duct injury in the form of an liver abscess? Is there an atrophy, hypertrophy complex, or because of prolonged biliary obstruction, these patients have secondary biliary cirrhosis or have developed portal hypertension? Broadly speaking, if you want to rule out a biliary collection, the investigation of choice is a CT scan. If a patient presents with a biliary fistula, majority of times the initial investigation is an endoscopic retrograde cholangiography. A patient who presents with obstructive jaundice is ideally first investigated with an MRCP, as is a patient who's got cholangitis. So if you ask me what is the best investigation for a patient who's got a post-cholecystectomy bile duct injury, my question to you will be, what is the presentation of this patient? So the ideal investigation depends on what is the presenting symptom of a patient who unfortunately has suffered a bile duct injury. Today, majority of patients undergo an MRCP because MRCP has many advantages. It is non-invasive. It's a one-stop shop. It tells you about the liver. It tells you also about a vascular injury. It can tell you about an intra-abdominal collection. Earlier, we used to do a PTC. PTC had the problem that it was invasive, and especially if you have hilus separation, it will only show one side of the ductal system and not the other side. So today, the gold standard of assessing a bile duct injury is an MRCP. How do we manage these patients? Needless to say, management of a post-cholecystectomy bile duct injury is a multidisciplinary game. The Department of Radiology, Gastroenterology, HPB surgery join hands in managing these patients because management of these patients can be very complicated, time-consuming, resource-intensive, and need a lot of thinking. Why do you need a skilled radiologist? A skilled radiologist is integral to a busy hepatobiliary surgical unit because not only they do an MRCP and tell you a grade of injury, they are very good, very, very important and vital members for draining collections, because if you have a good radiologist, you may not need to operate this patient. He can put proper sites, drains in the proper place, get the biliary collection out, and obviate the need for surgery. There's a subgroup of patients, which we will discuss later, who might need preoperative biliary drainage by transhepatic catheters, and a skilled radiologist is a great help in achieving this. Some patients, unfortunately, along with bile duct injury, also have an associated vascular injury. This is a disastrous complication. These patients have hemophilia, and the only life-saving maneuver in these patients is to do an angioembolization of the aneurysm of the right hepatic artery majority of times, and that can be life-saving. And today, patients who have recurrent strictures are possibly ideally managed by a skilled radiologist by transhepatic dilatation and stenting. Why do you be associated with a smart endoscopist? A good gastroenterologist is a great asset to a hepatobiliary surgeon because he's prudent enough to decide when to do an endoscopic retrograde cholangiography. We must remember that ERCP is not an innocuous investigation. It can lead to complications, and those complications can be lethal. So an endoscopist should be very prudent and should understand when an ERC helps. And if you see a patient who's got a cystic duct stump leak, a good endoscopist will put a stent there, and that can be absolutely curative. There is an ongoing interest in managing patients of bile duct injuries by endoscopists. Yes, a subgroup of patients are candidate for endoscopic management. So a gastroenterologist should be prudent enough to decide which are the patients who are candidates for endotherapy, because with each failed procedure is subsequent surgery. So an endoscopist should be wise enough to understand that this is the patient I can help, and this is the patient who straightway goes up for surgery. Look at these two different patients. Now, the first patient has got the continuity of the bile duct is maintained. You can see with the ERC is done, both right and left ducts are being opacified. There is a side lateral injury to the bile duct, but the continuity of the bile duct is maintained. In this patient, I will agree with my gastroenterologist that the best management is to place a endobiliary stent because the bile duct continuity is maintained. Whereas in the next patient, you can see the surgeon has been very aggressive. There are multiple clips across the bile duct. In this patient, there's a complete cutoff. Trying endotherapy in this patient is a waste of time, and this patient should go straight for surgery. So based on the cholangiogram pattern, you can decide what is the patient who's going to benefit from surgery. Over years, I've realized that I understand that patient, once you are a surgeon and you've damaged the bile duct, you are trying very hard that this patient should not go surgery, should preferably be managed by stenting. This is understandable because you do not want the patient to undergo surgery. But one must conquer one's fears and realize that endotherapy is not going to work in some patients. So if you postpone your surgery, the results of surgery ultimately will be poorer. So you have to swallow your guilt, swallow your ego, and refer the patient early for a reoperative surgery. The problem of endotherapy is that it is time consuming, it's expensive. Patients have to come again and again for change of stents. The long-term data of efficacy of stents is missing. It is useful in a selected group of patients. And actually, if you ask me, it is flawed in principle because we as surgeons are always taught that you should have a healthy mucosa. There should be a mucosa to mucosa anastomosis. And when you put a stent, you push the stent across unhealthy, ischemic, scarred part of the bile duct. I don't understand how this is going to stay patent over long term. So the endotherapy is flawed in practice. We always keep telling our juniors that the stoma should be wide, it should be a healthy part of the bile duct, and we should use a vascularized part. So whereas a stent uses an ischemic and fibrotic part of the bile duct. There's often a discussion that if you have a patient, this is more relevant in patients who have a external biliary fistula. Should you operate early or should you operate delayed? The best operation is if a bile duct injury is detected on the operation table, on-table repairs are the best repairs, provided they're done by an expert. Trust me, doing a hepatico-jejunostomy bile duct is not an easy procedure. If one is not trained to do that, it is best not attempted. There is abundant evidence in literature that on-table repairs which are done by non-HPB surgeons will fail 90% of times and make subsequent surgery difficult. This is one of the commonest mistakes made, that an injury has occurred and when somebody tries to do a makeshift procedure, it does not work. The damage shifts higher into the porta hepatis and makes surgery most difficult. The best thing in this situation is if one does not have the facilities or the skills, the thing is to put a drain and refer the patient. Early repair for external biliary fistula, like somebody you done a laparoscopic cholecystectomy, the bile is draining, it is 2 weeks. It is sensible to wait. There are studies where people have done early repairs, but these studies are a very small number of patients. And in a patient who suffered a complication, you don't lose anything by waiting. Delayed repairs give best results because the inflammation in the subhepatic space has settled. The bile ducts are not friable. You can assess the injury very well. So most hepatobiliary surgeons today believe possibly delayed repairs give better results. A situation like this, you open up the abdomen to drain the bilioma and you see these clips. It's very tempting to open the clips because you can avoid a second surgery. But trust me, you repair such a bile duct which is friable, it won't hold sutures, you'll have post-op leak, there'll be greater complications. So just drain the biliary collection, be patient, and then come back later after 6 to 8 weeks after inflammation is settled. Those hepatico-jejunostomies work better. So, like I said, the best thing is to put a drain there, convert it into an external biliary fistula, wait for a while, come back and operate in a comparatively non-infected, non-friable, and healthy subhepatic space. The essence of bile duct repair is to do a hepatico-jejunostomy. the concept of hepaticojejunostomy is based on the fact that we have to use a healthy and vascularized part of the bile duct, and the stoma should be as wide as possible. If you see the anatomy of the bile duct, the right duct immediately goes into the liver, and the left duct has a longer extrahepatic course. So this is the part of the left duct which we approach. No matter where is the injury, we always extend the stoma to a left hepatic duct because that's vascularized and healthy, and that helps you to make a big stoma. So when you open up these patients, that's what the abdomen looks like. The whole subhepatic space is frozen. So the trick is to come from the lateral to the medial side, put the colon down, bring the base of segment 4. The liver is retracted back, and the trick is to go to the base of segment 4, and that's where the bile duct lies. So you lower the hilar plate, open the bile duct, and it's very important to make sure that you drain all the bile ducts. Very often what happens is that the right posterior sectoral duct is separate. You must realize this. A preoperative cholangiogram helps to see that. You see, like in this patient, the left duct, right anterior, right posterior. So many times there are 2 or 3 ducts in the hepatic hilum, and all of them should be included. And you take an isolated loop of jejunum and you do a mucosa to mucosa anastomosis using 4 OPDS or a 5 OPDS. You can see in this patient, if you do not realize, the right posterior sectoral duct can very easily get occluded, and many of these patients will later present with cholangitis, and you will not understand. You'll think, I've done a good anastomosis. Why is this patient getting cholangitis? So majority of patients are served very well with the Roux-en-Y hepaticojejunostomy. There's a subgroup of patients, a small number of patients, in whom possibly a hepaticojejunostomy is not a good procedure. They might need a right hepatectomy and a left hepaticojejunostomy. Patients who have an atrophic right lobe, which occurs because of an injury to the same side right-sided portal vein, or patients who have prolonged biliary obstruction, the right lobe of the liver gets atrophy, the left lobe gets hypertrophy. So in these patients, the atrophic right lobe becomes a source of sepsis, so they are best managed with the right hepatectomy and left hepaticojejunostomy. In some patients, occasionally what happens is, because of an ischemic injury, the injury extends to the right duct. Now, like I said, the right hepatic duct goes immediately into the liver, so approaching it is not possible. Then these patients possibly are best managed with the right hepatectomy. We are also realizing with our experience over long term that some patients who have a Strasbourg type E4 injury, what is called as a bismuth 4 injury, in which the right and left ducts are separate, also probably hepaticojejunostomy over long term does not give good results, because these injuries are associated with a vascular injury, and over long term follow-up, when you follow up these patients get cholangitis and they have problems. So if you have a picture like this, where you can see the right lobe is atrophic, the left lobe is hypertrophic, and that's what intraoperatively looks like. You can see the right lobe has become so small, the left lobe is hypertrophic. So if you try doing a hepaticojejunostomy in this patient, it's not going to work. So the best operation in these patients is to do a right hepatectomy and to do a left-sided hepaticojejunostomy. Like I was telling you that when we had our experience of 16 patients in the last 10 years who had bismuth 4 injuries, when we did a hepaticojejunostomy on them, 90% of them over follow-up had one or the other symptom. They had cholangitis, they kept coming back, they had deranged LFTs. So we had to go back in some of them and do a hepatectomy, which was complicated. Now it's our belief that if you have a patient who's fit enough, who's got a bad bismuth type 4 injury, possibly the best operation in these patients is to do a right hepatectomy and do a left hepaticojejunostomy, because you approach the left duct in the liver, which is healthy, well vascularized. So long-term results in these patients are better. I'm not saying that all patients need a right hepatectomy, but I'm saying if you see that the anatomy is bad, the ducts are not healthy, then possibly it's better to do a right hepatectomy. Also, there is a subgroup of patients in whom, if you have sepsis, never operate these patients. If you operate a patient who's got cholangiolytic liver abscesses, this patient will die because biliary sepsis is lethal. So if you have a patient like this who has multiple cholangiolytic liver abscesses, then it is much better to do a preoperative PT-BD, control the sepsis, and then go in and operate these patients. So one of the indications of preoperative biliary drainage is a patient who's got cholangiolytic liver abscesses. Also, when you have complex injuries, this is one of our recent patients who had a very complex injury. You can see the entire 3 biliary ducts are totally separate. So this is a very major injury. This patient had an injury to the hepatic artery. So operating these patients is very difficult. So what we did in these patients, we did a PT-BD in these patients. Then we opened up. You can see the PT-BD catheter in this patient. You can see there's a left duct and there's a right duct. Both ducts are separate. So putting a percutaneous biliary drainage just before surgery was helpful. And you can see this is another patient in whom, when we have operated this patient, in the previous patient, we brought both the bile ducts together. But in this patient, we could not do that. There are 2 separate enterotomies and 2 separate hepaticojejunostomies in these patients. So in such patients, putting a preoperative biliary drainage keeps the area dry, helps you to identify the bile ducts, prevents a post-operative leak. So in a selected subgroup of patients, a preoperative PT-BD is helpful. Despite the best repair you do, about 5 to 30% patients may have a recurrent stenosis. How do we define a successful repair? A successful repair is a patient who is asymptomatic, does not need antibiotics, and has near normal liver function. So if you follow patients for long term, about 5 to 30% patients might have a recurrent stricture. Patients who have higher injuries, who have multiple previous repairs, who have associated cholangitis, associated portal hypertension, they are more prone to get a recurrence of stricture. Needless to say, experience of the operating surgeon is of paramount importance. This is not a surgery to be done by fly-by-night surgeons. If you occasionally do a hepaticojejunostomy, my advice to you is don't do it, because this is an operation which is very difficult to do. The portal vein just lies there. And in that small area, if you have bleeding, it is very difficult to control. And doing this operation needs technical skill and experience, and is best done by a hepatobiliary surgeon. Because if not properly done, or if delayed, that's what happens. Patients develop secondary biliary cirrhosis. Then no amount of treatment works, and then these patients ultimately need a liver transplant. You see what a sad state of affairs is, that a patient who just comes for a simple cholecystectomy, because of a damage done, improper management, failed repairs, develops secondary biliary cirrhosis and ultimately needs a liver transplant. This is one of a patient who had 3 repairs before he came to us. We tried to do a hepaticojejunostomy, didn't work. Ultimately, this patient had to undergo a liver transplant. Once you have a recurrence of stricture, today, majority of our patients are managed by a percutaneous transhepatic stenting. Thanks to our skilled intervention radiologists, they can do a good job. A small subgroup of patients, about 10 to 15% of them, we go back again and do a revision hepaticojejunostomy. But if the liver is bad, they develop portal hypertension, then the only choice is to do a liver transplant. So this is possibly my last but one slide. So what is the ideal treatment for a post-cholecystectomy bile duct stricture? The ideal treatment is prevention. We need to change the culture of laparoscopic cholecystectomy. It's an operation which is taken very casually. This is an operation which is a potential for lethal complications. So we need to respect this operation. We need to formulate policies in each unit. Like in our department, it's a policy that if you ever have to apply a large size clip on the cystic duct, you always have to call another assistant or a surgeon to see that is it the cystic duct or is it the bile. We believe that there are no anatomical anomalies in porta hepatis. All structures are the bile duct unless proved otherwise. The third rule is the threshold for converting to open cholecystectomy should be very low. The patient has not made a deal with you to always do a laparoscopic cholecystectomy. The patient has a deal with you to do a safe cholecystectomy. Many times injuries have occurred because the surgeon has insisted on continuing on doing laparoscopy when he knew that things are wrong. And the fourth policy is that when in trouble, call for help. Don't try to do things you have not done. There's a French saying, don't fly if you don't have wings. Don't try doing a hepatico-jejunostomy. And most important is audit your own events. We learn by our mistakes. A bile duct injury is a lethal complication. If not properly managed, the patient becomes a biliary cripple. Thank you very much for giving me this opportunity. I'll be very happy to answer any questions. These are my publications. I have a great interest in managing bile duct injuries. And over the last 15 years, I've done my major interest has been bile duct injuries. And that's what I've been doing, managing patients with bile duct injuries. And I've learned so many lessons in this journey. I'll be very happy to answer your questions. Thank you so much.
Yes. Dr. Basu, yes. Please unmute yourself.
You have to unmute yourself.
I hope I didn't take too much of time.
Sir. Thank you very much for your exhaust and the very good talk. So I'll ask the audience question one by one. So first thing,
Dr. Basu, before that, we'll have to ask the second quiz question.
Yes.
I'll request Meryl to kindly share second quiz question.
And Dr. Basu, there are few questions in the chat box also. Please see.
Have you shared the second quiz question?
Just
Because
second quiz question.
1 second. Yeah, sharing, sir. 1 second.
hello.
We already have a winner for the first question. The second quiz question, as you can see, is what is the most common reason for a bile duct injury? So, what is the most common reason for a bile duct injury? You have to give an unclicking that box. First quiz. Dr. Basu, I think you can in the meantime start
yes.
Chat box as well as
there's a question in the chat box which I've read, which said that which says that how do we manage a isolated posterior sectoral duct injury? So if you have a right posterior sectoral duct injury, then it's you recognize it on the operation table. It is better to do a hepatico-jejunostomy to it. You know, we have a belief that, oh, we should tie these ducts. No, if right posterior sectoral duct is not a small duct, if it is there, it is best incorporated into the hepatico-jejunostomy. Because if you just ligate it, the right posterior sectoral duct segment might go into atrophy, but it might not go into atrophy. Then these patients keep getting cholangitis. So if possible, you should try to do hepaticojejunostomy with that right posterior sectoral duct. The next question is any role of ICG in reconstruction? There is no role of ICG in reconstruction to my knowledge. Yes, there is a role of ICG in prevention bile duct injuries, that if you use ICG, it can delineate the biliary tract. I have no personal experience of this, but I know there is data that if you have ICG, possibly it helps you in identification of the bile duct. There is a question by Samir Rege. What is the treatment of isolated vascular injury at porta? Very rarely you have isolated vascular injury in porta. I mean, in a laparoscopic cholecystectomy, the treatment is to reconstruct the vessel. But if you see if it's a portal vein, it must be reconstructed. If it's a right hepatic artery, it is very difficult to reconstruct it. In a jaundiced patient, you will always have to reconstruct the right hepatic artery. But in a jaundiced patient, you will not do a lap chole. So possibly, I'm not saying that you can ligate it with the right hepatic artery, but many times you can get away with just ligation of the right hepatic artery in majority of patients. But the portal vein has to be repaired. So there is a sorry.
Adarsh, a posterior sectoral duct injury which presents in the post-op period as a external biliary fistula. This is Roy Patankar.
Yeah, Roy, I agree with you that if it is it will present as that's a very good question, because what happens is that it's an interesting story that in these patients, unless you are aware that you do an ERC, Roy, you will see the right and left ducts. You will say everything is all right. Where is this patient leaking from? So you put a stent, he continues to leak because the right posterior sectoral duct is there. Roy, I think we have operated many of these patients. If you go in, majority of times you can find that duct. But in these patients, it is much better to put a preoperative catheter into the right posterior sectoral duct, and then you can reconstruct a hepaticojejunostomy. Yes, you might say that you can get away with ligation also. I agree with you that in some patients it may not cause anything, but it also can cause cholangitis. But I agree with you that if you cannot find the duct, then you have to wait. And then many a times the right posterior sectoral duct gets atrophied, segment gets atrophic, it gets atrophied, or if it causes cholangitis, you can later do a right posterior sectionectomy. So the other question, Roy, do you agree with me?
I always agree with you, Adarsh.
No. One question is there.
Do you make access loop in? There's a question that do you make an access loop? Access loops people used to make earlier, but now it's most people don't make access loops because they don't are of any use, because it's very difficult to use an access loop. Today with skilled radiologists, most management is done transhepatically and we don't need to use access loops.
Sir, what is your opinion or advice when a surgeon called you that I have done a bile duct injury on table, and should I send this patient to you and you repair within 1 week or like that?
That's a very good question. If the patient is if the surgeon is in Delhi or something, I'll always ask him to call somebody else close by who's a trained hepatobiliary surgeon to do a repair at the same time. If he doesn't have help, I will say best thing is to put a drain and refer to us. And if he's referred to us, say within 24 hours, we might go in again and do a hepaticojejunostomy. I cannot say 36 hours or 48 hours, but we will try to do it.
Sir,
a little late. Then
another small tips I want to know from you for the juniors. So where to put the drain? 2 drains or 1 drain?
You might put 2, 3, 4, 6. I don't mind it, but I thought you will say, some people used to say that suppose the bile duct gets damaged, you must tie it with a big black suture so that the surgeon can later identify it. So I always say that if you are referring to a surgeon who needs to a silk suture to identify the bile duct, don't send it to him. We identify bile ducts by their anatomy, I'm just joking with you. Because what happens is
just asking you very importantly, In
let me
Sage's
finish.
manual, it is written that two drains should be placed. One is suprahepatic, one is subhepatic. Is that so?
I will not be able to answer this. You may put one or two, but whatever it is, sometimes you might have to put three, but I will tell you two or three simple things. One thing is when these patients are operated, always open the lesser sac. What happens is that you put a drain in subhepatic space, some bile stays in the lesser sac, the forum of Winslow is occluded, and that is the one which gets infected and causes problems.
Okay.
So if you go, always open the lesser sac, wash it well. And I am like you, my preference also is put two drains because these patients are dangerous patients. You see, you don't lose anything by putting two drains. But if sepsis goes uncontrolled, it is lethal.
So, sir, your message is very clear. Don't try to ligate the bile duct and don't send the patient after 48 hours. That's all?
No. What I'm saying is that my first message is you need to respect laparoscopic cholecystectomy.
Yes, sir. Yes, sir.
I mean,
yes,
if you have any doubt, just convert it into open. And I have always respected surgeons that who put in a laparoscope and see the gallbladder is very inflamed. You come out, don't operate, go back after 6 weeks. So the art of war also says the same thing, that a good general is not one who always wants to fight. Sometimes you retract, go back again. I mean, there is no ego that I have to do this gall. So I think most errors are avoidable. Most errors are avoidable.
So, sir, your take-home message is to the new surgeons: don't try to repair yourself. Send to sir like this.
No. I never said it. No, please don't get it wrong. What I'm saying is that what happens, I'll tell you two or three things. First of all, when you damage the bile duct, your mental state is so shattered. You cannot do a hepatogenoscopy because you see, I have done complications in my life. I know at the same time your confidence gets so shattered. Second, in an average nursing home, the light is poor. You don't have 5 OPDs. You're the only surgeon. There is no assistant. So there is nobody else to help you. I'm not saying that if you have a big OT, you have people who help, definitely do it. But I know that you don't have instruments. You don't have the skill. You don't have the suture material. So these problems are genuine. And there is no harm in, I have been to at least, I can count 13 court appearances for bile duct injury. 13. And in 9 of them, the surgeon was absolutely, no damage was done because he referred the patient. The judge asked me that, is there any malpractice? I said, no, there's no malpractice. Incidence is known, 0.8% to 1% is known. That's what has happened. He is recognized and referred. But in 2 instances, what happened was that this patient was not informed. Patient was not informed. And in 2 instances, they tried to repair without knowledge. So problems occur in these contexts.
Thank you, sir. Dr. Vishwarup, you conclude this session.
Yes. I hope everybody have enjoyed the discussion. And it is a very common operation, and the cholecystectomy and the subsequent bile duct injuries I hope many of us have faced those things. So the knowledge take-home message is also very good. And thank you, Dr. Adarsh Chaudhary and Dr. Abhimanyu Basu for speaking so nicely and moderating the session. And the EC members and the other members, Deboshi is still listening, and our president.
I have some announcements to make and some give the results of the quiz also.
Yes, please.
We had asked 2 questions during the quiz. The first was, which is the most common type of bile duct injury? The answer has been given the fastest by Dr. Chandrasekhar. That is the name which we could get. And with the email, that is a class 3 injury. And the second the question was, which is the most common reason for a bile duct injury? The answer was misidentification or misinterpretation of the normal biliary anatomy. That has been given by Dr. Kramer. That is the only name which we could get. We have their emails. We'll send them an email. Both of you are eligible for 5,000 rupees prize, but you have to be a MRC member to get this prize. So in order to become an MRC member, you'll have to log into mrc.org and fill up the form and do the needful. We will, if you are a PG student also, you can become an associate member. And after passing out your PG, you can become a full member. Now also, you'll have to become a member to be eligible for the award. Along with it, I have few announcements regarding MRC to be made, which is right. This is our website in which you can go and become a member, and this is for the students who have got. And there we have the bursary awards also going for MRCCon 2023, which will be held in Raipur. All these awards, today's awards also, everything you'll get it in Raipur only. So I'll request all of you to log into the website, of the conference also, and register yourself for the conference which is coming up. Bursary awards is a separate award. You have got this award, you can apply for the bursary award also. I request all the PG students to apply for the bursary awards. That will almost take care of their travel and the registration with this bursary awards. All details are given in our website as well as the MRCCon website. Our next lecture of the series is on 1st of June, which is the first Thursday of the month of June, which we are having with the Sri Lankan Association, who's of laparoscopic surgery and robotic surgery, which is coming up with us. This topic will be on hiatal hernia and anti-reflux surgery. We'll have three speakers. We'll have Dr. Vinod Menon, Dr. Harish Kumar, and Dr. Venkatesh Jayanti from UK. And it will be moderated by Dr. Chaturanga and Dr. Roy Patankar, who is the treasurer of MRC also. And the convener will be Dr. Samir Rekhe, who is the president of June. We have to also announce, give you information regarding the LaproSurge, which is coming up from the 6th to the 8th of July, the Mecca of laparoscopic surgery, that is Coimbatore. We invite all of you to attend LaproSurge from the 6th to the 8th. Registrations are going on regarding this conference also. It will be a great event, and request you all to be there. Finally, but not the least, we have our MRCCon 2023 from the 2nd to the 5th of November. Again, speaking about the conference, that registrations, bursary award, abstracts, everything are going on. Our early bird rates have been extended till 15th of May. I request all of you to take advantage of that. Thank you all.
Thank you, Dr. Devoshi, for this information. And I hope everybody have enjoyed. So we can conclude today's online CME program. Thank you very much for attending the CME. Thank you, everybody. And Dr. Adarsh Chaudhary, particularly, thank you very much.